interesting round of the session that would be focusing upon some important questions. So after every couple of turns, we would be having certain question and answer sessions so that I'll be able to discuss the important questions related to the subject of cons and endo, which are important for your examinations. So in today's session, we have got a couple of questions over there as they are listed on your screens. And I would try to select the questions as per the sessions that have already been taken so that it is easy for you to remember them and it would be a sort of revision for that. Okay. So let us start with the Q&A session today, and as displayed onto your screens, the question number 1. So basically the fundamentals of tooth preparation and excess cavities we would be focusing upon. The recommended horizontal angulation of X-ray tube for correct identification of the root canal morphology in mandibular second premolar is. It is asking about the horizontal angulation of the X-ray tube cone. 20 degrees, 30 degrees, 40 or 50 degrees. Now it is talking about mandibular premolars. Mandibular premolars, most of the time, are single rooted teeth. Okay. So one would expect that a straight on 90 degrees X-ray is sufficient to analyze the root canal anatomy on the preoperative radiograph. But most of the time that is not the case, because if you remember that mandibular premolars are also called as endodontist's enigma because there are highly chances of variable root canal anatomy. In such cases, to clearly visualize the root canal anatomy and features like bifurcation and trifurcation of the root canal. Okay, so what we talk about? We are talking about a mandibular premolar. This is a mandibular premolar as seen on the radiograph. With a straight on X-ray, it would be a single rooted tooth with a single canal in it. But once we vary the horizontal angulation, we would see that a single canal is dividing into one or two canal in the same plane. Means a root is single, but canal is dividing into two, or there is trifurcation of the root. So we have to vary the angulation, and all of you must be aware with the slob rule or the buccal object rule. Whenever we move the cone of the X-ray mesially, the object situated lingually would be moved mesially, and the object situated buccally would be moved distally. So same side movement is for the lingual object, and opposite side movement is for the buccal object. So to visualize the root canal anatomy, we have to vary the horizontal angulation for mandibular premolars 20 degrees to 40 degrees. Variation of horizontal angulation. It is for mandibular premolars. Okay. But the question is specifically asking you about mandibular second premolar. As you can see on the screens, it is asking about mandibular second premolar. So mandibular second premolar, it would be specifically 40 degrees. Okay. For second mandibular premolars. If it is asking about the first premolars, it would be in the range of 20 to 40 degrees. So one important distinction you have to keep in mind, there is variation from first to second premolar. First premolars in the range of 20 to 40 degrees. For second premolar, it would be 40 degrees. So what would be the answer over here? The answer would be option C over here. That is 40 degrees. Option C for question number 1 is the answer. Okay, I'll return over to question number 2. The most common pattern of accessory canals in a mandibular first molar is. Now it is talking about pattern of accessory canal in a mandibular first molar. A single furcation canal from pulp chamber to the intraradicular region, lateral canal from the coronal third of a major canal to the furcation region, both lateral and furcation canals, middle third canals. For this, if you remember that you have been taught that there are three patterns of accessory canals in mandibular first molars. Okay. In 10% cases, in 13% cases, and in 23% cases, there are three different patterns. So, in 23% cases, there would be a single lateral canal. In 10% cases, there is a both lateral and furcation canal. In 13% cases, there is a single furcation canal. This is the pattern of distribution for accessory canals in mandibular first molars, 10%, 13%, and 23% cases. The question is asking you about most common pattern. Most common is in the 23% cases, there would be a single lateral canal. So if this is a mandibular first molar, the mesial side, the distal side of it, this is the original root canal anatomy. Okay. There would be a single lateral canal in the distal aspect, coronal 2/3. In the distal root, coronal 2/3. This is the most common pattern. So, lateral canal from the coronal 2/3 of major canal to the furcation region, single furcation canal from the pulp chamber, both lateral and middle 1/3. Option B would be the answer, the best possible answer for question number 2. If you look at the previous sessions where we have discussed about these tooth morphology and access cavity preparations, these things have been clearly explained. Okay. Coming over to question number 3. Question number 3. The tooth that shows all the 8 possible canal configurations according to what you see is. It is a straightforward question. Mandibular first molar, maxillary first molar, mandibular first premolar, or maxillary second premolar. If you remember, it is maxillary second premolar that has shown all the possible 8 canal configurations according to what you see. So the answer to question number 3 would be option D, that is maxillary second premolar. This is something you have to remember. Coming over to question number 4. The type 4 isthmus is characterized by. Another straightforward question. We could asking you about the classification of isthmus. If you remember, KIMS classification of isthmus into 5 classes. The class 1 isthmus is an incomplete isthmus between 2 canals. So in the single root, there would be 2 canals and an incomplete isthmus between them. What is class 2 or type 2 isthmus? Type 2 isthmus is a complete isthmus between again 2 canals. So there would be a single root, 2 canals, and a complete isthmus type 2. What is type 3 isthmus? Type 3 is a very short but complete isthmus between again 2 canals. So there would be a single root, 2 canals, short and complete isthmus between them. What is type 4 according to what you see? That is what the question is asking us. It is 3 or more canals are there with either complete or incomplete isthmus. So in a single rooted tooth, there would be 3 or more canals with complete or incomplete isthmus. Some of the isthmuses would be complete. And if you remember what are isthmus, they are narrow ribbon-shaped spaces or communications between 2 root canals in a root which contain pulp or pulpally derived tissue. And finally, type 5 means 2 or 3 canals without visible connections. without visible connections are there, 2 or 3 canals. So this is the classification. Again, I have repeated it according to what you see. The question is asking type 4. Type 4 would be 2 canals with a definite connection between them. No. Complete or incomplete isthmus between 3 or more canals. Yes. 2 or 3 canal openings without visible connections is type 5, and very short and complete isthmus is type 3. So answer to question number 4 is option B, a complete or incomplete isthmus between 3 or more canals. Okay. Now coming over to question number 5. The space between the minor and the major apical diameter of the root canal has been described as the shape of. Okay. How do we describe the space between them? The space between, so we are talking about question number 5. This is the typical root canal anatomy. The anatomy view of the apical one third of the root. This is the apical constriction, and this is the apical foramen, and there is a fan-shaped space between them, between the minor and the major diameter. The question is asking, how do you define the space? It is defined by 3 terms, either hyperbolic in shape, or funnel shaped, or shape of morning glory. Hyperbolic in shape, funnel shaped, or shape of morning glory. So these are the 3 terms which are used to define the shape of space that exists between the apical constriction and the apical foramen. So if we look at the options given in question number 5, hyperbola, parabola, ellipse, or cone, the correct answer would be option number A, shape of hyperbola. Coming over to question number 6. The most important anatomic landmark for determining the location of pulp chambers and root canal orifice is CDJ, DEJ, CEJ, or AC, that is apical constriction. If you remember that the rules for the access cavity preparation, they were given by Kressner and Renko, and they were based on principally 9 important principles for determining the location of root canal orifice, then their pulp chamber anatomy. And according to the Kressner and Resco cemento enamel junction present in the cervical one third of the teeth, it is the most important, okay, and repeatable landmark. It is the most consistent and repeatable landmark for determining the location of your pulp chambers and root canal orifice. So for option number C is the answer to question number 6. Coming over to question number 7. Question number 7. The burr that is used to locate a calcified orifice in a receded pulp chamber are all except used to locate calcified orifice in a receded pulp chamber. So there is basically a tooth with the receded pulp chamber, and the root canal orifice have gone down. Calcified root canals are there, thin orifice are there. Which burr would be used for them? All except Munz burrs, Endo burrs, Muller burr, or Allen burr. We normally use extended shank burrs for locating and opening the orifice which are situated deep inside the pulp chamber. Extended shank burrs. If you remember, a burr has got three parts: head of the burr, the neck of the burr, and shank of the burr. So, for discovery of location of deep-seated root canal orifice in calcified pulp chambers, we use extended shank burrs. Example of extended shank burrs are Allen burr, that is also called extendo burr. Okay. Mun's discovery burrs and Mueller burr. Endo Z burr. So which burr is used and which is not used? We use Allen or extendo burr. They are one and the same thing. We use most discovery burrs. We also use Mueller burr, but Endo Z burr is not used for location of deep-seated root canal orifice. It is used for the regular access cavity preparations in a normal pulp chamber where the root canal orifice are located in their original position. Okay. So, which is not used? Question number 7, option B would be the answer. I hope all of you understand which burr is used for locating the deep-seated root canal orifice. Coming over to question number 8. Any remaining overhang in the pulp chamber roof, especially in the area of pulp horn of anterior teeth, can be detected by. What the question is asking? The question is asking how can you detect the residual overhang of the pulp chamber when making excess cavities, especially of anterior teeth. If we talk about anterior teeth like a maxillary incisor and look at it into buccolingual section, it would be having a pulp chamber and the root canal anatomy something like this. If we look at it from a lingual aspect, then the pulp horns are extended something like this, and this is the extension of the pulp chamber into the root canals. This is the pulp organ. And if you remember that the shape of the excess cavity for maxillary anterior or mandibular anterior teeth is like this in the form of rounded triangle. So whenever we make a rounded triangle excess cavity like this, there is always a likelihood that these pulp horns, they escape from elimination. And what is the disadvantage of leaving these pulp horns? During excess cavity preparations, they can be the source of infection of the root canal. They can be the source of discoloration of the teeth by way of degenerated pulpal elements seeping into the dentinal tubules. So we have to detect these residual pulp horns. Residual pulp horns. And this is especially present in cases of anterior teeth. For this detection, we can use an explorer. Your regular explorer is there. This is number 23 tip. All of you must have used Dental Explorer, and this is number 17 tip of the Explorer. This tip of the Explorer is best suited to detect these residual pulps. So, option number D would be the answer. If we look at the other options, DG16 Explorer. DG16 is an explorer which is used to locate the root canal orifice, not to detect the residual pulp horns. JW17 Explorer is also an endodontic explorer, a micro explorer used to locate the root canal orifice. Number 23 Explorer is this round end, and number 17 Explorer is this end. So it is basically the number 17 Explorer that is used to detect the overhangs in the pulp chamber in the area of pulp horns. Option D would be the answer. Okay. Coming over to question number 9. Question number 9. The starting location for the excess in mandibular first premolar is. Okay. All of you should remember that these are the basics of the endodontics have been taught. The morphology and anatomy of the pulp and the root canals, the variations in the root canal anatomy, the excess cavity preparations, and a lot of questions are coming these days on these topics. So it is simple as well as important for the examinations. The starting location for excess in mandibular first premolar is center of the occlusal surface, halfway up the lingual incline of the buccal cusp, one third the way up the lingual incline of the buccal cusp, on the groove, central groove halfway between the mesial and distal boundaries. For that, you should remember that a mandibular first premolar is a tooth, something seen from the above like this. This would be the tip of the buccal cusp, tip of the lingual cusp, and the central groove. If we measure the distance, this is the lingual incline of the buccal cusp. If we see the tooth from the side, it would be something like this. Okay. This is tip of the buccal cusp. This is tip of the lingual cusp. And this is the central groove. So this is basically the lingual incline of the buccal cusp. From the center, we measure the distance and 1/2. This is the starting point. The burr would be oriented to penetrate the tooth like this. So halfway up the lingual incline of the buccal cusp from the central groove is for mandibular first premolar. The starting point for excess cavity preparation. On the other hand, if the question is asking about mandibular second premolar, it would be 1/3 the lingual incline from central groove. Okay, the starting point for a mandibular second premolar, this is the tip of the buccal cusp. This is the lingual incline. We divide it into 3 parts. 1/3 the way up the lingual incline of the buccal cusp. So this is the technical difference. Halfway up the lingual incline of the buccal cusp, 1/3 the way up the lingual incline of buccal cusp. So question number 9. It is asking for first premolar. Option B would be the answer. If it is asking about second premolar, option C would be the answer. Right. Coming over to question number 10. Question number 10. The extra root of mandibular premolar is called Turner's root, Dome's root, radix entomolaris, or radix paramolaris. A straightforward question. The answer would be Dome's root. The extra root of mandibular premolar is called Dome's root. What is radix entomolaris? It is the extra distolingual root of mandibular first molar. What is radix paramolaris? Extra mesiobuccal root of mandibular first molar. Okay. Okay. Coming over to question number. So option B would be the answer for question number 10. Question number 11. The category 2 C-shaped root canals are characterized by a single round or oval canal, a continuous C-shaped root canal, a semicolon shape with both angles alpha and beta less than 60 degrees, a semicolon shape with either angle alpha or beta no less than 60 degrees. Okay, so C-shaped root canals, they were Cox and Cook who initially identify the C-shaped root canals, and Melton and Selzer. Melton and Selzer They classified into three types: category 1, category 2, and category 3. Category 1 is a continuous C-shaped root canal. This is a continuous. Category 2 is a semicolon shaped. So if we look at the options, option C and D can be the answer, but there is an add-on to it, a semicolon shape with two angles alpha and beta less than 60 degrees, either angle not less than 60 degrees. If we geometrically define them, alpha and beta, they are the two angles which are geometrically used to define the anatomy of C-shaped root canals. Then they should be greater than 60 degrees. So if we look at the options, option D would be the answer. Okay. If we look at the other C shape of that, here, 2 or 3 canal orifice in C shape are present with both angles alpha and beta less than 60 degrees add on. Category 4 C-shaped root canal is a single oval canal as given in option number A, and category 5 is no canal orifice. There is just a C-shaped groove present. Okay. These are the 5 categories of C-shaped root canals originally identified by Cox and Cook. The question is asking you about type 2. And so add on, you have to remember that two angles alpha and beta are described for category 2 and category 3. In category 2, both the angles are greater than 60 degrees or either of the angles is greater than 60 degrees. But in category 3, both the angles alpha and beta are less than 60 degrees. This is the distinction between category 2 and category 3 you have to remember. And also that most common teeth to display the C-shaped root canals are mandibulars, second molars. Okay, coming over to question number 12. Question number 12. For irrigation in the pulp chamber, to visualize the canal, what can be best used? The question is asking the irrigation solution to visualize the root canal. What agent is used for flushing of the pulp chambers? 5% sodium hypochlorite, 17% EDTA and 95% ethanol, 2% chlorhexidine and 5% sodium hypochlorite, EDTA or chlorhexidine. Now this is a little technical question. The question is basically asking you, suppose we are doing root canal in any particular tooth. After making excess cavity preparations, the question is asking, how do we clean the pulp chamber of all the organic tissue so that the root canal orifice can be identified clearly? How do we clean the orifice for irrigation of the pulp chamber? So to clean the orifice, we use a combination of 17% EDTA plus 95% ethanol. Okay. It meticulously cleans the pulp chamber. Sodium hypochlorite is not used for cleaning the pulp chamber. Sodium hypochlorite is used after cleaning of the pulp chamber in a champagne bubble test to locate the root canal orifice. The question is asking which reagent or chemicals are used to clean the pulp chambers, combination of these two. So option B would be the answer to question number 12. Another section that we are talking about is related to the diagnosis of the pulpal anatomy. Question number 13, or first question of the diagnosis section. While taking dental history of the patient, the format that is followed is SOAP, Poor Past, ELARA, or ICDAS. So these are all abbreviations for the concepts that are used. SOAP format is basically used for taking dental history. SOAP stands for subjective findings are recorded first, then objective findings are recorded, then appraisal means we assess the subjective and objective findings, and finally we make a treatment plan. Subjective, objective, appraisal plan. Okay, we first take the history of the patient, record the patient's subjective findings, then make objective clinical testing. Then based upon the subjective and objective findings, we make appraisal of the situation, we assess the clinical situation, arrive at a final diagnosis, and then accordingly we devise a treatment plan. So option A would be the answer to question number 13 or question number 1 of the diagnosis section. Okay. What is poor past? For determining the prognosis of particular teeth, we use the poor past thing. LRI is the principle of as low as reasonably achievable, that we should use always the minimum amount of radiation for any clinical situation. ICDS is International Caries Detection and Assessment System. So answer would be option A. Question number 2 for diagnosis that we are seeing is to trace the origin of the sinus tract. The size of the gattaparcha used is, at times there are teeth, multiple carious teeth can be present, and there's a sinus associated. Clinically, it is difficult to determine which tooth is responsible for the sinus. In such cases, to determine the origin of sinus tract and to find out the offending tooth, we use fistulography. The procedure is called fistulography. This is the stoma or opening of the sinus. Through this sinus, we thread a gattaparcha cone till the time of maximum resistance. This is gattaparcha cone. If the patient is feeling pain, we can numb the area. Then choose a suitable gattaparcha cone. The gattaparcha cone is number 25 to number 30 GP cone. That is used for your fistulography. And we keep on inserting the cone till the time we feel the resistance, and then we take X-ray for the patient. So the point of termination of the gattaparcha determines which tooth is the offending tooth, and this procedure of identifying the tooth that is associated with sinus formation, the procedure is called fistulography, and the size of gattaparcha cone used is number 25 or number 30 gattaparcha cone. If we look at the options 15, 20, 25 and 35, option C is the answer over here. Okay, coming over to the next question. The pulp sensibility tests are subjective, objective, predictive, or definitive. Pulp sensibility tests. They are. Now, please do not get confused. Although the pulp sensibility tests, okay, they are conducted by the clinician. Pulp sensibility test. They consist of two types of tests, the thermal testing and the electric pulp testing. The thermal tests are of further two types, the cold and the heat test. So cold test, heat test and electric pulp testing They are called pulp sensibility tests because they rely upon sensory nerve fibers of the pulp. And two type of sensory nerve fibers are present in the pulp, A delta and C nerve fibers. So whenever we apply some stimulus, whether heat, cold or electric current, we wait for symptoms or response from the patient. The patient says that I am feeling pain. We record it as pain. The patient does not report any pain. We do not record it as pain. So they are all subjective tests. They rely upon sensation from the patient. If the patient does not report any sensation, we cannot document the findings. So option A would be the answer. Pulp sensibility test. On the other hand, tests like pulse oximetry, laser Doppler flowmetry, they are purely objective tests. We do not have to wait or rely upon the response from the patient. They are purely objective tests. Okay. Coming over to the question number 4 of the diagnosis section. The pulp testing method most suitable for teeth with full coverage crowns. Full coverage crowns. Laser Doppler flowmetry, electric pulp testing, dry ice, or heated gutta percha. The pulp testing method for teeth with full coverage crowns. Now, if you look at the options, laser Doppler flowmetry is the most accurate method on all the tests available for diagnosing the pulp vitality status. But here it is talking about teeth with full coverage crowns. Full coverage crowns can be either metal crowns, they can be either PFM crowns, or they can be metal free ceramic crowns. So if there is a tooth which is covered by a full coverage crown, a vital tooth, and we have to check the vitality status, we cannot use laser Doppler flowmetry. Why? Because the laser light would not penetrate the thickness of these full coverage crowns and would not give accurate readings. Electric pulp tester also cannot be used in most of these situations because there is no tooth structure available to directly place the electric pulp tester and we cannot generate a response. If we talk about solid carbon dioxide, it is a temperature of negative 78 degrees Celsius. This is one of the coldest testing agent. So whether it is a metal crown, whether it is a PFM, or whether it is a metal free crown, if we put solid carbon dioxide onto the full coverage crown, it is cold enough to stimulate the A delta nerve fibers, if at all viable fibers are present in the pulp. So dry ice can be used. Heated GP again is not sufficient to penetrate the thickness of full coverage crowns. So it is solid carbon dioxide, although it is not as accurate as laser Doppler flowmetry. And LDF is present in the options. Do not get confused. For teeth with full coverage crowns, we can use solid carbon dioxide. It is preferred. So option C would be the answer. Coming over to the next question. Question number 5. A cold stimulus for pulp testing should be applied for 5 seconds, 10 seconds, 15 seconds, or 20 seconds. What does it mean? It is asking about cold pulp sensibility test, that is a protocol of agent application. Whatever cold testing agent we have chosen, we apply that agent. And this agent is applied, if we talk about the area of application, it is the midfacial area of tooth. always any cold testing agent is applied. If we talk about the duration of application, then it should be maximum 15 seconds for cold testing. Beyond 15 seconds, there are likely chances that we would damage the viable pulp. Our purpose is diagnosis, not to damage the teeth. So, option C would be the answer. If it is asking about heat testing, the duration would be 5 seconds maximum. Okay. Coming over to question number 6 of the diagnosis section. The preferred temperature for heat testing of the pulp is 55 degrees Celsius, 65, 75 degrees Celsius, or 85 degrees Celsius. Now, what is this question is asking you? Heat testing of the pulp. For this, you should be knowing the principle of testing. Heat testing is a pulp sensibility test, isn't it? This heat testing stimulates the C fibers, which are present in the core of the pulp. And if you remember that these C fibers are polymodal nociceptors that are stimulated by temperature greater than 110 degrees Fahrenheit. Okay, which is nearly about 65.5 degrees Celsius. Any temperature below this would not be sufficient to cause a stimulation of the C fibers. So 65 degrees, option B, is the best possible answer to question number 6. Heat testing of the pulp. Okay. Coming over to question number 7. The sensitivity of the heat test for pulp is 41%, 71, 83, or 86% sensitivity of the heat test. We know that pulp sensibility test like heat, cold, and electric pulp tester. These are 3 types of pulp sensibility test. If we talk about their accuracy, then heat test is the least accurate test method. Okay. Cold test is the most accurate method of nearly 86% accuracy, and electric pulp tester 83% accuracy. It is accuracy. But if we look at the question is asking you about sensitivity. Sensitivity. There are 2 terms, specificity and sensitivity. Sensitivity means there is low incidence of false negative results. A high sensitivity test means it has low incidence of false negative results. On the other hand, a test with high specificity means it has a low incidence of false positive results. Low incidence of false negative results means it has the ability to find the disease. Okay. If we discuss about the ability to find the disease, that is called sensitivity, then heat test has a sensitivity. It is the most sensitive test, 86%, followed by cold test, 81%, followed by electric pulp test of nearly 71%. This is sensitivity, and this is accuracy. A test that is highly sensitive and highly highly specific and highly sensitive both is called most accurate test. The most accurate test is cold test and most sensitive test is heat test. So option number D would be the answer to question number 7. The sensitivity of heat test it is asking. So please do not get confused between sensitivity and accuracy. Coming over to question number 8. The tip of the electrode for electric bulb testing is placed on mesiobuccal cusp tip, distobuccal cusp tip, mesolingual cusp tip, or distobuccal cusp tip. You all know that we have to choose the cusp with highest bulb horn. And if we have the knowledge of dental anatomy, we know that the mesiobuccal bulb horn is the highest. So we would prefer mesiobuccal cusp tip for placing the electrode of electric bulb tester in sensibility testing of posterior teeth. If we talk about anterior teeth, what is the position of the tip of electrode? It is the incisal ridge. We have to place the electrode tip in the areas of highest neural density, which are likely to find the maximum number of A delta nerve fibers. They are present in the region of pulp horns. Pulp horns are present below the incisal edges for the anterior teeth, and they are present below the cusp tips for posterior teeth. And which cusp tip has the highest pulp horn? The mesiobuccal cusp. So the preferred location is mesiobuccal cusp tip for posterior teeth and incisal edge for anterior teeth. Option number A would be the answer to question number 8. Question number 9. All are true for EPT except EPT results are most accurate when no response is obtained to any amount of electric current. All true statements except one statement we have to find out. False positive response is obtained in cases of partial pulp necrosis. The response of pulp to EPT reflects the histologic health or disease status of the pulp. Adjacent and contralateral teeth are tested first. If we talk about options one by one, option 1, it is most accurate when no response is obtained to any amount of electric current, is correct because we are doing a subjective test. Patient's response is recorded. So we keep on increasing the current. Suppose the patient is giving response on the level of current 2 on 3 and 3 and 4. It becomes confusing what is the status. If no response is given to any level of current, maximum current we have given, but no response, we can most likely predict the pulp to be having degenerated or no viable nerve fibers are present. So most accurate EPT is there when no response is obtained to any level of current. Option A is correct. False positive response is obtained in cases of partial pulp necrosis. If there is a multi-rooted teeth and there is suppose a viable pulp in one of the roots, but majority of the pulp is degenerated, that viable pulp would give pain sensation to the patient. So it is called false positive. We would falsely assume the pulp to be vital. Then the response of pulp to EPT reflects the histologic health or disease status with the pulp is not correct. Why it is not correct? It never gives an idea about the true histologic status. It simply indicates whether viable and responsive sensory nerve fibers are present or not in the pulp. Adjacent and contralateral teeth are tested first is true for all pulp sensibility tests, whether it is heat test, cold test, or EPT. We always test the adjacent and contralateral teeth to establish a baseline response. So which option is not correct? Option C is not correct. About EPT would be the answer over here. And finally, we'll talk about question number 10 for the diagnosis session. LDF uses, LDF stands for laser Doppler flowmetry, red laser, infrared laser, excimer laser, or soft tissue laser. Okay. Which laser is used? For laser Doppler flowmetry, we use 632.8 nanometers near infrared laser. What is infrared? 700 nanometer onwards is infrared. So this is a red near infrared laser. Option A would be the answer over here. Which laser is used? We use helium neon laser for laser Doppler flowmetry, which has a wavelength of 632.8 nanometer, and this is designated as near infrared laser. As near infrared is not in the options, the best answer would be red laser. It is in the red region of the visible spectrum. Option A is the answer to question number 10 in the diagnosis session. Okay. This is all about today's session of Q&A. We have discussed the important questions related to the tooth morphology and excess cavity preparations, as well as the diagnostic aspects of your pulpal or endodontic conditions. With this, I conclude today's session. See you again in the next session. Till then, happy reading. Good night, everyone. Thank you for being connected with me. Thank you so much.